Good morning to you all. We are already late by a couple of minutes. And welcome you all to this instruction course on... I request my co-instructors to please come over to the dais. So there's a very interesting course on surgical management of proliferative diabetic retinopathy. And probably one of the most common surgical procedures that we do today is managing advanced cases of PDR. And with the development of microincisional vitreous surgical techniques, the outcomes are improved and we have become more aggressive as far as selection of cases are concerned. We have a very distinguished faculty for this particular IC, and we'll be starting the course with the first talk by Dr. Lingam Gopal. He has to go to the adjacent hall where he himself is conducting an IC on ROP. So, we start the... So he'll be talking on diabetic tractional retinal detachment and vitreomacular traction.
Okay, again, my sincere apologies for rushing between halls. I guess we couldn't help it. This is a presentation on diabetic TRD and vitreomacular traction. At the outset, I would like to thank Dr. Giridhar for having invited me to be a part of his course. We all know that there are two important locations when surgery would be required in diabetic retinopathy management in terms of non-proliferative diabetic retinopathy as well as proliferative diabetic retinopathy. Even in the milieu of NPDR, epiretinal membranes and VMT could be an indication for surgery. And in PDR, of course, we know lots of indications which will be discussed by various speakers in this session. So is pre-retinal traction always an indication for surgery? If you see these cases, they look quite significant traction pre-retinally and retinal thickening. But does that mean, and this is a vitreomacular traction, but we do admit that the vitreous is not that condensed like what we expect. So would these be indications for a vitrectomy prima facie, or would you like to attempt anti-VEGF? So this is the same cases, pre-injection and post-injection. As you can see, there has been reasonably good response, although the pre-retinal membrane is still quite thick here, the macular edema is resolved. And the recurrence occurred only after 4 to 5 weeks, which could occur even in eye without pre-retinal traction. So presence of pre-retinal traction doesn't always mean surgery is mandatory, but somebody who is not responding, then of course you would definitely consider. And again, it's a gray area. There are a few cases where you say it will never respond, you will definitely go in for surgery. So in a DME with ERM, the options are surgery to remove the epiretinal membrane and also administer anti-VEGF at the same time. Or you give anti-VEGF, see the efficacy. If efficacy is good, sometimes even they're like partial vitreous detachment can become a total PVD across the macula, and there may be no more residual traction. But in the presence of a membrane, you would definitely ignore sometimes in cases where there are other reasons for poor vision, like an optic atrophy, a totally sclerosed vessels, in general a very poor prognostic eye with a lot of macular ischemia. You're not worried about a little bit of pre-retinal traction there. The problem is much bigger than just the pre-retinal traction. So in coming to diabetic TRD, which is in the milieu of a proliferative response, one should understand the pathoanatomy, when the posterior vitreous detachment is present or not. And we know by present, I mean even if it is present in a small location. We know that PVD will never be total in a case of diabetic retinopathy unless in very select cases. In most cases, it will be stuck in some place or other due to the abnormal fibrovascular attachment. But when we say present, is it present at least in some locations? Because that makes our surgery a lot more easier. The severity of vascularity, and one should understand the concept of vitreoskisis, wherein the vitreous is split into multiple layers, and each layer can be fibrotic. So it's not that there's just one second membrane and one PVD. There can be multiple membranes, and each would need to be addressed in your surgery. The extent of retinal ischemia and the consequent thinning, which is what dictates how much traction the retina can withstand when you do the dissection. And the strength of the vitreoretinal attachment, that is the ease with which the membrane can be removed. Is it peeling or is it cutting that is required? This picture just gives you an idea as to how you as a surgeon can assess what is the degree of difficulty you're likely to face when you do vitreoretinal surgery. Now this is an eye where the retina looks not too bad, and there's a pre-retinal membrane, pre-retinal hemorrhage, which tells you obviously that there is vitreous separated on this area. And there is some amount of gliosis, but not too much of TRD, etc. So likely that surgery could be fairly simple, where you just open up this area and extend the vitreous detachment all around, and the whole thing can get lifted up. But there are always situations where there are areas where it's strongly adherent, and if you're not conscious of the fact and violently detach the vitreous, you can actually tear the retina. Now consider this case where the retina is a little more ischemic, the disc is more pale, and you find again a preretinal hemorrhage, which tells you that in this area, definitely the vitreous is likely to be detached, and this can be a starting point for your dissection. While the case on the top right is a little more advanced disease, where there's a TRD, likely there's no PVD at all. You get a large fibrovascular tissue which is pulling on the retina. But here also you can find sometimes planes of dissection to start with. But this is probably the worst case scenario where you find a florid disease, very thick fibrovascular tissue, but see the retina on either side of this area. It's absolutely ischemic, there are no vessels seen, and the whole thing is pulled down. So this surgically is going to be a lot more difficult than the first three versions. So some amount of idea you'll have. So when do you operate in diabetic TRDs? We all have been taught about extramacular versus TRD involving center of the macula. I don't think there's any controversy. But what about TRDs bordering on the macula? That's where the controversy arises. When you assess it clinically, sometimes you're not sure whether the macula is actually involved in the traction or not. But OCT comes to our rescue. It tells you exactly whether the fovea is detached or not. There may be thick membranes in front, but OCT cuts through everything and tells you precisely the anatomy of the fovea. And there are many cases where preoperatively or clinical examination told us we should operate, but OCT told me we should not operate. And you should also match the visual acuity to the macular traction. There's also confusion sometimes between a trampoline membrane, which is across the macula, versus actual traction on the macula. The membrane can be bridging between the arcades, but may not be actually pulling on the fovea at all. And these patients can have excellent vision as long as the fovea is not ischemic and not unhealthy. How about extensive TRD all around the macula, but macula is still attached? These patients may deceptively having good visual acuity, but they have hardly any field of vision. And functionally, they are really not good at all. So you may be having 612 or better vision, but all around the fovea retina is detached. There may be indications for surgery despite visual acuity. So visual acuity is not the sole criteria for deciding when to operate. What about possible reasons for not operating? A very thin atrophic retina, grossly sclerosed blood vessels, and gross optic atrophy. I'm sure each one of you in this hall must have had experience where each one of these are not a contraindication for operating. That despite a pale disc, despite sclerosed vessels, and despite a thin-looking retina, they have recovered useful vision. So these are all relative contraindications. I'm not saying absolute contraindications. So ultimate decision maker is your assessment of what is the visual potential versus the anticipated complexity of surgery. The basic principles would revolve around core vitrectomy. I can't stress too much on the need for debulking the vitreous. Leaving too much of vitreous in the periphery, as we used to do in the pre-wide-angle visualization era, is not a good option at all. So you must remove most of the vitreous gel. You may do it before inducing PVD, and before initiating a membrane dissection, and before leaving peripheral vitreous undetached. Means you have detached the vitreous in the posterior pole, but the whole peripheral vitreous is stuck. When it is stuck and you know beyond this I can't detach it, at least debulk it. So don't leave it like a thick vitreous gel in the periphery stuck to the retina in the periphery. So before all these three steps, you must debulk the vitreous. What about membrane dissection? You can do as a combination of peeling, delamination, and segmentation. I won't go to the details because ultimately it's what you are comfortable with, and in a given case scenario, you may switch from one to another back and forth. A divide and conquer is a useful technique rather than trying to remove it and block, because that makes it easier for you, number one. Number two, you can also judge the anatomy underneath the tissue rather than having an opaque tissue covering your area of dissection, and it also allows you not to create retinal breaks at a faraway point when you're dissecting at one location. Attempt not to leave residual tissue. I said attempt because there are cases where you think you push yourself to a limit and say, beyond this I'm going to cause a break. Maybe it's best to leave a residual tissue than cause a break, especially if the tissue is nasally located or far away from the equator where it's not likely to cause traction on the macula. Let's just take a sample case. I thought no presentation on diabetic TRD would be complete without showing a video. It's just to show you that you can keep the cutter on the tissue and cut towards you, so there's no risk of retina getting sucked in. And this technique used with the 25 gauge instrument is probably enough to remove most of the scar tissue in diabetic TRDs these days, where you cannot use always divide and conquer and then use the scissors to to dissect. With the with the 25 gauge instruments, your need to use cutters, scissors is far less than it used to be in the past. So you can see the vitreous, which is not even visible, was actually detached, and that enabled the delineation of actual fibrovascular attachment, which could be cut with scissors. And then, of course, the next step is very easy. So the initiating the membrane dissection is different between the 20 gauge instrumentation technique with 23 and 25 gauge. With 25 gauge forceps, you don't need a sharp needle, you don't need a scratcher, etc. Directly with the forceps, you can hold the membrane. Since you can hold ILM, you can hold this membrane as well, and then try to dissect it. So you always catch the membrane at where it is least taut, not the taut membrane, because that doesn't lend itself to grasp. So you go beyond at a point where it's hardly visible. There you can catch it, then you can hold it easily and peel it towards the more strongly attached, more densely fibrous tissue. Pulling the plug over the disc also gives you a large area of separation around the posterior pole from where you can dissect into the periphery. It's always preferable to dissect from periphery to center, but there's no dogma. You can always start from center as well. But because the central vessels connecting the vessels, fibrovascular tissue to the retina are more thicker, they can bleed a lot more. So you prefer to start from periphery and then come to the center. So this change in approach with MIVS, especially 25 gauge. Okay, I think I'll quick slip this video. Beware of hydrogen retinal breaks that can occur at a point removed from the area of dissection. Breaks can be camouflaged by pre-retinal hemorrhage. There's a difficulty in differentiating between thin retina and a broken retina, and a surgeon goes into the mode of denial, thinking it's not a break, it's not a break. Better to think it is a break and treat it at this point of time than trying to avoid treating it, okay? Management of intraoperative bleeding, good control of systemic status preoperatively. GA is preferred in florid disease, preoperative anti-VEGF, intermittent raise in infusion pressure, etc., etc. And the story goes on and on with the next speakers. Thank you very much for your attention, and again, my apologies for leaving you early. Thank you. Thanks, Giridhar.
Thank you, Gopal. Time for 1 or 2 questions, answers, etc. 2 minutes. Yeah. Any questions to Gopal? Yeah.
So I just wanted to ask you that what would be your tips for avoiding a recurrent vitreous hemorrhage in these cases, which we very often are now encountering after we've shifted to MIVS?
I don't think there's any increased incidence after MIVS. I probably beg to differ on that. But yes, to reduce the risk of recurrent hemorrhages, we all know that removing all tissue is very useful. Leaving behind residue always lends it to reproliferation and again bleeding. And the amount of ischemia also dictates why it rebleeds. If there's more ischemia, you try to ablate more of the peripheral retina. Intraop, make sure that you treat all the way up to the ora and try to reduce the amount of ischemic response for the eye in general. And if there is a rebleed, of course, you inject anti-VEGF. Giving injection of anti-VEGF on the table is a very good way of reducing post-operative bleed. At least the anti-VEGF will act during the immediate perioperative period and reduce the risk of new hemorrhage occurring. And if still it rebleeds again and again, and inspect the sclerotomies with UBM to see whether there's any anterior highlight proliferation.
Do you prefer
Another point is that you must do a good base excision, especially inferiorly. You have a lot of this clotted blood in the aura, and you leave a lot of blood there. The immediate bleeding actually is the blood that oozes from that area. The residual blood that you leave at the periphery just oozes after surgery. So it's very important to clear the periphery very well, adequately, so that as much as possible. Sometimes some things are stuck close to the lens, which we can't do anything. But otherwise, you know, all this clotted blood in the periphery has to be removed, because there has been a recent paper about 2 years ago where they have shown the difference between the immediate post-op vitreous hemorrhage in eyes where this base removal of vitreous hemorrhage was not done, and eyes where it was done, and they showed that there's a significant decrease in the amount of heme immediate post-op after surgery. So that's also another important,
And do you
apart from all that Gopal Sab said.
That's where vitreous debulking that goes to that.
Then one more point, I mean, Gopal, just before you leave, I know you have a course there, but you said about the inferior thick vitreous gel, and sometimes, you know, beyond the equator, it becomes very difficult to remove the tissue. So what is your advice? Just leave it there and give adequate laser?
Yeah, I think if it's adequately lasered, as you try to reduce the amount that you can, but beyond a point, you know, you don't want to risk a retinal break when everything is good posteriorly. And if the vitreous is very condensed, this is the problem arises. If it's gel, it's okay, you just debulk it. But in general, you try to push your dissection till the fibrotic tissue is removed. And leave the gel, it's still okay, but leaving fibrotic tissue is always
Always a
uncomfortable
problem
endpoint.
because reproliferation.
It's not a good endpoint. Well, plus minus. I don't know how much belt buckle will protect it, but yes, theoretically it can. If there's residual traction and there's a TRD underneath it, then I would support it. But if there's no
Yeah.
TRD, I would be reluctant to add a belt buckle.
The BB doesn't prevent reproliferation.
Sir, just a last point
So-
about the point of injecting anti-VEGFs at the conclusion of surgery. If you are using tamponade in the form of gas or oil, the timing of the injection of the anti-VEGF, is there a technical difference between when you inject, before oil or after gas? I mean,
I'm not sure whether it makes a difference, but basically I think you inject it at the end of surgery. But with oil, I was not very enthusiastic about injecting same time anti-VEGF.
Anyway, thanks
Yes.
a lot,
Thank you.
Gopal. And we have one more talk by our guest faculty, so we can ask him also some questions. Dr. Kamal Kishore is here. We move on to the next talk by Dr. Mahesh, and he'll be talking about a very important indication for vitrectomy, that is dense premacular hemorrhage.
Thank you, sir. LG sir has given his the pearls in vitreous surgery by his vast experience. I will be just adding few points, that's all. Indications of vitreous surgery has changed over the last 10 years, probably in diabetic retinopathy. The conventional indications and the new indications like recalcitrant edema, taut hyaloid, then vitreomacular traction, and clearing of the media. Like a lot of new indications are there, but I will be talking specifically on premacular hemorrhage. We faced three groups of patients: treatment-naive patients, post-PRP patients, and long-standing cases with thick premacular hemorrhage. So these are the three things that we come across. So there are some issues. Premacular. Should we immediately advise surgery in a treatment-naive? Patient comes suddenly with this thing. That is one issue. Should we give laser PRP little and then wait for a month and then do the surgery? Theoretically, this causes more fibrosis after a month. You will find it more difficult to inject. Role of anti-VEGF preoperative or intraoperative already discussed. So these are the three things that will come across our mind when we see a patient, especially treatment-naive cases. So intravitreal anti-VEGF, we know that it prevents intraoperative and postoperative bleeds. So when to operate? Conservative management will result in severe premacular fibrosis and more intraoperative problems that all of us know. So we operate as early as possible, not the same day or something, just little laser. That individually differs from surgeon to surgeon. Ultrasound B scan definitely is useful, because once we decided surgery, we have to decide where to start. Like some of the premacular hemorrhages have peripheral little separation of the PVD hyaloid, where we can start. In those cases where there is PVD, we can start from the periphery as much as possible, truncation, and then come to the center. But sometimes there will be nothing in the separation, so we'll have to start from the center. All of us use the standard methods: 23, 25, 27, high cutting, close shave, viscodissection in some cases, bimanual, chandelier, wide-angle viewing system, complete removal of membranes, good hemostasis, adequate laser, and tamponade. This is a standard thing that all of us do use. Now, this is a case which presented like this. Montage shows large premacular hemorrhage. So immediately I could not advise surgery. So I gave little laser, waited for 2-3 weeks, nothing happened, then suggested surgery. Preoperatively, in these sort of cases where it is very vascular, I give little anti-VEGF injection and then take up for surgery. So this is the separation. We know that the central part, there is separation of the hyaloid from the retina, where always we can go. This is the ultrasound B scan. Periphery, not much. And luckily in this case, upper part periphery has little separation. So I will show the video. This is over 1 month, nothing happened, so advise surgery. So this is surgical treatment. Truncation, if PVD is present in the periphery in B scan, like this I showed, the upper part had some PVD, so I started in the periphery with opening of the hyaloid, and as much as possible. If no PVD, start from the center. We can use it, if you are using 23 gauge, you can use a 24 gauge needle through that opening and make an opening in the center. Otherwise, you can use the cutter itself. Nowadays, we don't use second instrument because of the small gauge vitrectomy systems. So once you clear the debulk the vitreous before going near the retina, debulk the vitreous, already these points are discussed. Then if the hyaloid is separated, that area you can make an opening, and as much as possible. The experience will tell you when to stop before doing damage. So that all of us learn from our mistakes only. So truncation if PVD is present. Then membrane peeling using the cutter itself. Nowadays we don't use a second instrument. Cutter itself we can peel the membrane. Keep a watch on the traction where be careful. The tear may be, it may tear definitely an atrophic retina especially, and never make an, try never to make an iatrogenic tear inferiorly, because if you make an inferior tear, it is difficult to, it will most probably that it will redetach in that area. So iatrogenic break, always avoid the central area. So as much as possible, peel the membrane using suction very carefully. Then can use forceps for peeling. You can feel the traction where it is present. In this case, used only cutter. You can use up to the central area there was PVD in the upper part, so I could use the cutter itself for peeling till the central area. And open the macula, that hyaloid over the macula. Wherever there is dense adherence, stop there and go to the other side. Some people use viscodissection and vertical scissors can be used, but most of the time it will not be necessary. Go to the center, just feel that there will be definitely a gap in the central area. You can make an opening with the cutter itself. Leave segments of islands, segmented islands. Then there is a layer of blood over the macula. You can try with flute, and most of the time what happens is, if you always look for second membrane, because when we use the flute, it is not coming up very freely. You can see there is another layer under the hyaloid. Always look for the second membrane. That area there is another layer under. So that is why the blood is not freely coming to the flute. Then trim the rest of the areas with the cutter, peel and trim. Should not avulse the proliferation from the disc, which may start oozing, and it will be difficult to stop the bleeding. And the basic principle is that you attack the most vascular part at the last. And finally, air or gas or silicone oil according to your judgment. If you have not made any iatrogenic break, you can very well do away with air or gas in case of these cases. Good hemostasis, pick up most of the bleeding points, good hemostasis, good laser all around. So this is, and many of these cases we use intraoperative Avastin to prevent the re-bleed. So this is one case which had a pre-retinal hemorrhage, operated in the right eye. This is a B scan showing dense pre-retinal hemorrhage. Absolutely, there was no PVD in the B scan, so we have to start from the center. And ultimately, this is the post-operative picture, pre-op and post-op. He gained very good vision with 6/9 vision. Now, what will happen if you, this is another case with the right eye and this is the left eye, bad preoperative premacular hemorrhage. This patient was not willing for surgery, little laser was given, graded, and you know what happened at the end after 6 months, the thickening of premacular, and this is the end result. If you don't do anything, usually if you don't do the premacular hemorrhages, this will end up like this, dense premacular fibrosis with final visual acuity will be bad. So better results, we have to operate premacular hemorrhage with optimally early surgery. I don't have a number, 1 month or immediately or anything. So optimally early surgery to provide good visual outcome. Thank you for the kind attention.
Any questions to Dr. Mahesh from the audience? Any questions, comments? Yeah.
I am Dr. Kamrul. I am from Dhaka, Bangladesh. Regarding premacular hemorrhage, subhyaloid hemorrhage, I have two experience, dense hemorrhage, and I have given intravitreal Avastin. After giving Avastin, visual acuity improve and blood goes down. And I was decided to do surgery, but I give one pre-surgery, one intravitreal Avastin to reduce the bleeding. But after giving Avastin, after 15 days patient come, my vision is improving. Then I wait, after 1 month I give one Avastin, now his vision is 6/9. This side of 2 patients. I decided to do surgery, but before surgery I want to give Avastin to reduce perioperative bleeding. What is that?
All of us have that sort of experience. That is why I said optimally early surgery. I didn't tell you any number. Because all of us, in some cases, PVD gets induced gradually and blood clears. Only if the blood remains there and causes premacular fibrosis, it happens.
You
like
usually give Avastin preoperatively?
I don't know. It is before surgery only we use Avastin. For
Before
clearing
surgery.
the blood, Avastin, especially in a premacular case, I may not.
Yeah, I mean, we don't use Avastin as a primary treatment of premacular hemorrhage. What you said is true, and what happened in your case might have happened even without the Avastin. I mean, it's not that the Avastin may not be primarily responsible, because many of these cases we do see that a natural absorption of the hemorrhage sometimes bursts into the vitreous cavity, half of it comes in, the remaining absorbs. So all these things are possible. So, when you look at the hemorrhage, but when you see a large, dense premacular hemorrhage with a taut hyaloid, usually many of them don't really disappear. That's why we don't operate, when a patient comes to you with a 1-day history, it's not that we're going to operate tomorrow. We mentally prepare the patient. We just tell the patient, look here, this is a condition. There is a possibility that you will need surgery. And then we mentally prepare the patient and wait for some time. It's not that, within a day or two we start, it's not a surgical emergency.
And
But
you
then,
usually give preoperatively
and we give Avastin as a pre-operative device. We don't give Avastin as a therapeutic device for a pre.
How many days before operation?
We give it about 5 days before surgery.
Thank you, sir.
So any other question? Yeah.
Sir, I really wanted to ask you, do you also feel that there is a role of Avastin at the end of the surgery, as Dr. Gopal mentioned? Because recently there was a study published in Retina which apparently showed that there was no difference in the recurrent
I
vitreous
think
hemorrhage.
these are all individual, practice patterns, where some of them give at the end of the operating
Yes.
table. In our center, we don't.
Yeah.
In our
Once
center,
in a while, if
yeah.
the patient, if we have given good laser, no problems, all membranes removed, probably this may not be required.
yeah.
But some cases will have severe oozing, unhealthy, hypertensive, renal failure, very bad BP control. We feel that there could be a rebleed immediately after surgery. We give, but not under oil. Probably
I think
partial FA and little.
I think it will be a function of how bad the case was and how confident about the completeness of the surgery you have done. So it will be a function of both.
And the patient's systemic, some badly nephropathy, hypertension and all may have rebleed.
we'll have to move forward with the next talk by one of our senior consultants from Bangalore. And he'll again be talking on combined retinal detachment in proliferative diabetic retinopathy. Dr. K S Kumar.
Thanks, Dr. Giridhar, for including me in this instruction course. Combined retinal detachment also goes by the acronym of CTRRD, which means combined tractional rhegmatogenous retinal detachments. Among all the various causes of diabetic retinopathy which warrant surgery, probably the technically difficult one would top the list, and that would be a combined retinal detachment. Let us straight go to the clinical features. The patient may complain of a sudden drop in vision, but because these patients may already be having subnormal or suboptimal vision, the drop in vision may not be noticed by many, and it may be insidious too. It will have a convex configuration, but this configuration can be variable and pleat-like depending upon the extent of preretinal fibrosis. The only thing is these patients may not have the corrugations or the rugae that we see in a typical rhegmatogenous detachment. That is because of retinal edema, and because these eyes are mostly ischemic, one may not see those rugae or the corrugations in the retina. What is most important is this configuration is caused by the development of a break in the retina, and we need to dwell a little bit on these breaks. These can be obscured many times by media opacities, retinal folds, or even tissue, epiretinal tissue that is covering these openings in the retina. They may be slit-like, or they may be multiple and sieve-like, particularly if they are related to laser marks, or there may be ovoid tiny breaks along the vessels at the base of the fibrovascular proliferations, at the edge of laser marks, or it may even be a macular hole as a cause for combined retinal detachment. The geographic profile of the detachment itself is variable. It could reach the ora at least in some quadrants. It may not typically follow the Linkoff's rules, obviously because of the epiretinal tissue, as also the laser that might have been done in some of these cases. And occasionally one may have subretinal bleed and subretinal gliosis as well. Subretinal gliosis is particularly more common because these breaks are small, and the RPE, instead of coming onto the epiretinal surface, tends to form membranes underneath the retina. This is a typical photograph of a combined retinal detachment. One may not always be lucky to see the break, as can be seen in this patient. This is a wide-angle view of the same. What are the predisposing factors for a combined retinal detachment? Traction retinal detachment, long-standing, which may be extramacular itself, is a predisposition to combined retinal detachment. Heavy laser treatment, particularly in the situation of a vitreous hemorrhage, or at the edge of a TRD where the retina may be partially lifted, or laser over areas of superficial bleed can induce breaks in the retina. Or it can be iatrogenic. You're operating on a traction retinal detachment, a pure case of TRD, but iatrogenic breaks in that scenario is fairly common, and it may get converted into a combined retinal detachment. Or it can develop after anti-VEGF injections also, as has been reported in some cases, particularly with the use of bevacizumab, because it blocks all isoforms of VEGF. And we, of course, I have no experience with pegaptenib, but because pegaptenib only acts on the VEGF A165 isoform, it's thought to not so much predisposed to preretinal fibrosis. And that has been called as the crunch syndrome. We'll talk about that in a minute. Now, for our own discussion purposes, we can divide the combined retinal detachments into two varieties, either the central or the peripheral, or it can be associated with the active fibrovascular phase, or it can occur even in the late fibrotic phase. A typical case in point is this patient who had extensive new vessels on fluorescein angiography in his left eye. We did what we thought was fairly adequate laser, but a year down the line he bled again. We tried to do a pattern tightening laser, and with which the blood cleared up. 5 years after that, he presents just recently with a posterior pole TRD, which we were able to settle with surgery and silicone oil. So these are patients who can develop late as well. And this is an example of a combined retinal detachment in the scenario of active fibrovascular proliferation, as you can see in the top pictures, and these are the post-operative pictures. It may also happen in situations where we feel that the disease has quietened, has become quiescent with largely fibrosis, but there can be pulling up of the retina even in the fibrotic phase. What about the preoperative evaluation in these patients? One must carefully look for rubeosis. Laser any untreated retina, because that will make the surgery easier and shorten the surgical time. Search for breaks diligently under magnification. This is very important. There may be a tendency to believe that the retinal breaks need not be identified. We are anyway going in, we can create an iatrogenic break for endo drainage. As much as possible, we must try to identify the breaks, if not preoperatively, at least intraoperatively, because the more the number of breaks we create, each break individually increases the chance of a recurrent detachment. So there should be a very high threshold for creating any new breaks intraoperatively. About the role of preoperative Avastin, yes, in highly vascular combined retinal detachments, one could give that to reduce the neovascularization, with the clear caveat that these patients should be taken up for surgery no later than 5 days. Else, these patients may develop what has been called as the crunch syndrome, whereby the neovascular tissue regresses, but the fibrotic component of the fibrovascular proliferation becomes thicker, and the tissue planes are difficult to identify. And if the patient has comorbid conditions such as diabetes, diabetic nephropathy, or has some other issues which makes deferral of surgery required, then you would have lost the opportunity to go in with a vitrectomy, and that is the situation where probably this could be counterproductive. About the OCT biomarkers, outer retinal microarchitecture is more prognostic of the likely visual outcome, and even if the media is clear in these patients, we may take additional help of B-scan and an OCT to identify the tissue planes where we can initiate the surgical processes. The role of preoperative Ozurdex, some have used preoperative Ozurdex as well, as opposed to bevacizumab, for the various advantages that the steroids give us. The basic tenets in managing CRDs are just the same as was enunciated earlier. Media clarity should be ensured, and if this means removing a cataract that is also interfering with our vision, we must do that, because we are only as good a surgeon as we can see, and these surgeries may take a long time with a lot of maneuvers, intraocular maneuvers involved. So ensuring media clarity is primary, then clear all the opaque or even the clear vitreous as the case may be. Relieve anterior-posterior traction by truncating the peripheral vitreous cone to start with, and then go on to remove the tangential traction, as has been discussed already. Adequate hemostasis is very important. The maneuvers with which we can do that, we will come to it in a moment. Identifying the breaks are very important, as I alluded to already. Don't create any, or at least not many. And retinal reattachment, ensuring retinal reattachment is key, because these patients are at very high risk of developing postoperative rubeosis, and if it means due to intrinsic shortening of the retina, retinotomies or retinectomies have to be done, then those also have to be done. Endolaser and appropriate tamponade. Some intraoperative nuggets, no standard format can be given for a given case, because each case is a learning experience, and each case teaches us something. So we may have to be individualizing, improvising on the table, and ability to think quick on one's feet is very important. Basically, it involves dealing with the traction retinal detachment, even though it's a combined retinal detachment. So one cannot afford to leave the traction behind and try and reattach the retina without dealing with the traction. Recognizing the break is possible under high magnification or by the phenomenon of Claren, which we are all familiar with. Because of the higher viscosity of the subretinal fluid, fluid-air exchange may not suffice to drain the subretinal fluid in many of these cases. So a fluid-fluid exchange, which we will discuss in a moment, is the way. And when you do that, you can see sclerin. Reattaching the retina is the next step. You may use either fluid-air exchange or a fluid-fluid exchange or a perfluorocarbon liquid to do that, and then endolaser and appropriate tamponade. A role of adjuncts, if there is unrelieved severe anteroposterior peripheral traction, particularly in a phakic eye, one may use buckles. This is again an individual choice. Perfluorocarbons help in several ways. It helps to stabilize the detached retina during dissection, allows lower laser power in intrinsic retinal shortening. Many times when you do a fluid-air exchange, the retina is well attached, but when you try to do laser, you're not getting sufficient burns even with increasing the laser power. So in those situations, you get a really tight adhesion. And ILM peeling in CRD with full thickness macular holes also is a situation where adjuncts help. I will quickly go through the short video that I have. Differential diagnosis, one may have to differentiate it from a traction retinoschisis itself. A concave configuration, despite the presence of a break, would probably suggest that it's just a traction retinoschisis, but these are the eyes which have poorer prognosis, and RRD in a case of PDR. Impact of newer instrumentation has already been discussed. Intraoperative OCT is a useful adjunct which gives anatomic feedback, and these are some of the cases. I think my time is up. I'll go straight away to the video. I'll just take 2-3 minutes to highlight some of the facets of managing combined retinal detachments. The basic tricks are, as I said, you may have multiple solutions to the problem. I think, can I take a minute, Giri? Or you may have to think out of the box when you are confronted with a difficult situation. The first step would be, of course, to clear the media opacities in the form of either I'm not going to dwell on that a lot. Then we have to deal with the posterior hyaloid phase, and you may, in those cases where you feel the posterior hyaloid is easily amenable to removal with a vitrector, you use suction and try to go around circumferentially as far as possible. Of course, these are not possible in every case, but each case has to be individualized based on the pathoanatomy. Then we come to the epiretinal proliferations themselves. With the small gauge, high speed cutting instruments, you can do this with the cutter itself, as is being shown. And if there are any stumps that are really very adherent, you can then use the peeling technique. But most often in diabetic combined retinal detachments, you must be very careful about peeling, because these membranes are very adherent and vascular, and cutting with scissors or with the forceps is rather suited rather than trying to be more bent on peeling. This shows the residual membranes being chewed up with the cutter. And I am not going to show bimanual, so that is the break which we were discussing. That's the tiny break which we were able to identify. I'm sorry, there is a lot of blooming over there, but that's the tiny break. And then you assess the degree of adhesion of the fibrovascular tissue to the subjacent retina by trying to elevate. If the surrounding retina is ischemic, as evidenced by occluded vessels and atrophic retina, and you are not getting a lift, I'm showing only the unimanual surgeries which we used to do, because Giridhar will discuss about bimanual. The useful technique that we used to do those days was use the light pipe itself for counter traction, and that will really come in handy in some of these tough adhesions. See the second hand with the light pipe itself is giving counter traction and allowing us to go into the cleavage plane to remove these epiretinal proliferations. Of course, bleed under the subretinal, bleed under these membranes is an issue to contend with. I have only about a minute or so. I haven't edited that part because I thought we must focus on the area of attention last, as Mahesh was mentioning. Finish up with whatever is possible before you can do, such as laser, treat the rest of the retina, and come to the difficult part last. This shows the ectodiathermy being done along the bleeders from the tissues that we removed, and those stumps which are very hard and not amenable to removal by the cutter, we remove it with the scissors. And this is the fluid exchange that I was referring to. We have not put in any air, we are just using the suction with the vitrector and trying to get as much as the subretinal fluid out as possible. And if there is any residual tissue left over the disc and if it is not very adherent, it's better to get that off, as is being done here. Then you endodiathermize the break. And the point about removing all traction around the break, which we were discussing, is very important, not to shift to another area if we develop a iatrogenic break in the area of dissection, because that can cause a combined or a rhegmatogenous detachment to obscure the rest of the surgery. And when we remove all this traction around the break, you can see that the break limply falls back on the retina. And our surgery, many times one will have to get used to managing under suboptimal visualization, because intraoperative blood is a constant menace. And when there is oozing, it's better to address that issue quickly, otherwise we may be we may have an issue on hand where the whole that becomes another surgery by itself, removing the epiretinal blood. Then we do the laser and then the fluid air exchange and tamponade. Thank you very much for your patient hearing.
Very important topic. I mean, any questions, comments?
Yes, I have a question. Sometimes after you finish your PPV and hemostasis was controlled, then you inject silicone oil, and at the end of the surgery, after injecting the silicone oil, you find this premacular ooze. A lot of premacular hemorrhage develops again. I don't know, maybe pressure drops, or what should I do for that hemorrhage? Should I leave it and it will absorb, or should I manipulate?
Yeah, we have had these situations several times. If the pre-retinal hemorrhage under the oil is not too much, and most of the time it's not a torrential bleed. If it is very minimal, we can generally leave it behind.
Okay.
But if it is torrential, then obviously there is something that is still going on, and we have not done enough before we injected the silicone oil. Maybe we will have to seek recourse to removing the oil and seeing what exactly is going on, if it is really a very bad hemorrhage under the oil.
Okay, thank you.
Thank you. I think there are a lot of issues as far as the management of combined RD is concerned. I think we can discuss this later. He showed some of the techniques, unimanual techniques. Sometimes bimanual techniques are easier because the chance of iatrogenic breaks are much less, because there is no counter pressure, because when you peel a membrane on a detached retina, the retina also is getting pulled along with the peeling. So there is a high chance that you create a break, and sometimes these breaks occur far away from where you are actually dissecting. So these are some of the issues, but nonetheless he showed a wonderful video as to the management with unimanual techniques. And also sometimes you see that beyond the equator, that is from the area from where you have the combined RD with the break, you see a dense tissue which is adherent to the retina. And that's the sort of photograph that he showed in the montage. That again is a very difficult clinical situation, where again you may have to use bimanual techniques, because you cannot leave that amount of fibrous tissue on the surface without its removal, and that's a dense plastered tissue which unfortunately may not come that easily with unimanual techniques. So now we have a guest lecture by one of our good friends from US, Dr. Kamal Kishore. I think I would like to just introduce him to this audience. Kamal has been coming quite regularly now. He attended the VRSI meeting in Bhubaneswar recently and gave some wonderful talks. I would like to say that he has actually been practicing in the United States for the last 20 years as a vitreoretinal surgeon, and he is an alumnus of the All India Institute of Medical Sciences, where he has done both his undergraduate and his postgraduate medical education. Please, Dr. Kamal.
Thank you, sir. Thank you, Dr. Giridhar, for including me in this talk, and thank you for giving me this topic, which is very near and dear to my heart. And I would like to thank all the previous speakers, Dr. Gopal, Dr. Mahesh, and Dr. Kumar, for excellent tips. And you will see the purpose of this talk is to make it simple for you. So the surgical goal, the primary goal here is to reattach the macula. And of course, we have talked about removing membranes, hemostasis, PRP, and minimize delay complications, breaks, bleeding, etc. And of course, maximize vision. That should be the goal. Therefore, as much as possible, avoid the oil. And if you are using the oil, use it for short term. And we'll talk about it in a minute. So some of these cases can be very difficult, but if you remember these 5 things, you will have a plan. So first, in most of these TRDs, there is a peripheral PVD. The second, the posterior hyaloid and membranes are a continuous structure. And the idea is you should know that you can cause a break at a remote location far away from your area. And third is vascularity. We have talked about it. So Avastin 3 to 7 days before surgery. And usually, one area is the hardest one. The rest of it is not so hard. And as everybody has talked about, hardest part should be tackled last. And of course, remember retinal thinning and atrophy. And this is not cancer surgery. You can leave behind some membranes. It's not a defeat. So have a plan. So whether it's a game of chess or a military maneuver, have a plan. And of course, as the situation demands, you have to make adjustments. So what is my plan? So there are 5 problems, 5 things you have to know, and same thing, 5 steps. So as has been alluded to, remove anterior traction first. we all have seen patients who have extensive proliferation, but they never get TRD because there is no peripheral PVD. And then divide tissue between two temporal arcades. Third is find the easier one first. Just like a military operation, you will not going to attack the most heavily defended fort first. And don't be very aggressive with nasal membranes. We are not doing cancer surgery here. So cutter as multifunctional tool, we have talked about it many times. So use it for segmentation first. You break up the tissue as much as you can. You are using it like a vertical scissors. And it's a matter of individual taste. I like to use in dense fiber mode, except that you just don't have to use that much vacuum. There's a scissor mode also, where you have low cutting speed and low vacuum. And then delamination and membrane removal. So there are two approaches. One of them is fold back that we have talked about, where the cutter sits on top and that you allow the membrane to fold into the cutter. And the second is where you are operating in the plane of the retina. That's called conformal. So remember two essential maneuvers. One of them is if you can somehow get under the membrane. So just like imagine if you have an enemy or a political debate, you want to get under their skin. So that's what you're trying to do, get under the tissue if you can. If not, you are going to use the cutter like a shovel, like just to find space. And now let's see how it is done. So here, this is a case of CRD, combined traction retinogenous detachment. And notice how much time I'm spending just to remove peripheral vitreous, like Dr. Lingam Gopal said, as much as possible, find a place first, and then gently, gradually extend it, and spend your time, it's okay. And after that, you free up one of the arcades, and here you can see the inferior temporal is almost free. So I'll do all this before reaching the central part. And now you put flat lens on, see right here, you're trying to stick your cutter under it. And a very useful instrument here, which I recently found, is Alcon 25 gauge pick, lighted pick. It just got introduced, no commercial relationship, but it's very useful to give you counter traction. And this is fold back delamination. You can see cutter on top and the membrane folds in. And now this is conformal. So when you do conformal, remember that you want to lower the vacuum. Otherwise, it's very easy to create iatrogenic breaks. And you can see, just lower the vacuum and just be patient. Extra 1 or 2 minutes, and you have to find approach angle. So you may have to use a different area and see you can, and it's going to come to you. And where you cannot put the cutter in, you have to do bimanual. So you are not going to use any lifting with forceps. It's only to stabilize, because if you lift it, and just be patient. So when you use scissors, you are always cutting small snips. It's not like general surgery where you're trying to stretch or spread. No, it's just small snips, and one at a time, and here it is. And then you are basically done, and this is no oil, still phakic, 20/30 vision. And I have one more case. This is slightly more advanced, and you can see probably is. So here you have only partial PVD at the periphery, so it will take some more time, but still I'm going to spend a lot of time on it and create complete 360 degrees circumcision. And you can see it here, very gently introduce a cutter and just cut it and keep going. So here, this is Dr. Kumar talked about, if you don't have any place to dissect, go to the nerve. You will always find a place there. Lift it gently. And sure, if you are aggressive, you can cause damage, but gently you can lift it. And the same maneuver here, trying to get under the tissue. And it's going to be. And just small bites. And the best place is in the trough between two elevations. And this is what Dr. Kumar actually showed very nicely. And you can use the cutter as almost like a dissector, or you can use the light pipe, same thing. And if you have a break here, and that's the purpose of this video, if you have a break, don't worry, just relieve the traction around it. So this is the maneuver. It's almost like skinning an animal, and just gently do it. and you will see a break forming there, but no worries, it's okay. And you want to have hemostasis, but sometimes you cannot avoid it. But like Dr. Kumar said, if you have a break, you stay at the break and take care of the problem there first, and it's going to be fine. And this is fluid exchange followed by fluid air exchange. And retina will flatten and do laser. So many of these patients will have subretinal fibrosis. Ignore it. I have never had to remove it. No problems. Just leave it alone. So these are some of the patients I did. Another case, still phakic. This is a very important patient. So I did temporally as much as I could. Nasally, I left it, and the patient has done very well. Just air, nothing. So it's better to leave all this nasal tissue rather than trying to be aggressive here over atrophic retina and cause iatrogenic breaks. Only air tamponade was done. This is another one, and this is another one. Another one. In this one, I had to use oil because there was a big break over here, but still, I removed the oil about a month later, and 20/100 vision. There is some optic atrophy because of long-standing traction detachment. Thank you, and I'll be happy to take the questions.
I'd like to ask you the same question that I asked Gopal. There has been some mention in the literature about when to inject an anti-VEGF at the conclusion of surgery when you're using tamponade. If you're using gas, they say you have to use it before or when you, I don't know, what's the concept behind that?
Correct. So I always use tamponade before surgery, but I'll almost never use tamponade intraoperatively or because, anti-VEGF, so Avastin. And the reason is we don't know the pharmacokinetics of it in air-filled eye or silicone-filled eye. And also, if they have bleeding post-operatively, I can always give them Avastin post-operatively. So I don't use it at the end of the case. Correct. So correct. So the thing is that you gave Avastin pre-operatively, and the question is how much of that will stay at the end of air exchange. So there will be no Avastin left in the vitreous. That is true, but there will be some Avastin in the retina and in the fibrovascular area. So that's why I don't.
I mean, I am always wary of using Avastin at the end of surgery. In an eye in which I have done a fluid air exchange, I am going to use gas or silicone oil because we don't know. We are going to inject bevacizumab, and there is only a very, very small fluid compartment, and that bevacizumab in that small fluid compartment, to me, looks like too much of concentration of the drug. So if I am putting gas or oil at the end of surgery in PDR, I don't use bevacizumab. I use bevacizumab when I am not doing gas or silicone oil, and if I am doing a fluid air exchange just for the sclerotomy closure, I just do a very partial fluid air exchange and leave a very small amount of gas just to cover the sclerotomy so that there's no leakage, and I inject bevacizumab at the end at the end, right at the end. That's my take. I don't know.
That's a very good point. That's a very good point. But in general, I use Avastin post-operatively only if it's needed. So because not every patient will bleed. So if they bleed, what's the hurry? You can give them Avastin 2 or 3 weeks later.
Incidentally, I don't use bevacizumab that often at the end of surgery also, not very rarely.
Because you have a chance of getting a break when you are removing the membrane at the center in a TRD with diabetic. So you said you are wary of injecting oil. So I would like to know if suppose there is a break which is not seen on the table, and it happens, because if you have a bad TRD with diabetes, some amount of break may be there in the periphery, which may have been left because you are doing skirting and then focusing mainly on the center. So if there's a break in the center, you said you will not inject, you will just tamponade with the air. Suppose there's a break in the periphery also, in a difficult case, how often do you inject oil?
very rarely. I would say maybe not more than 10 or 15% patients. So the patients where I use oil would be the patients where there are large breaks, especially inferior breaks, unrelieved peripheral traction. Those are the patients I will use. But it doesn't matter where the break is. If you have relieved all traction around it, and if you have done laser around it after fluid exchange, and you put gas in there, that will work. And don't forget, not every break causes detachment. There are many posterior breaks, they never cause detachment. So that comes the question of missed breaks. So don't worry. You are seeing the retina under very high magnification. If you don't see any break, and you talk about the Schleeren phenomenon, if you don't see any of that, so the chances are there are no breaks there. And even if there's a small break somewhere, that's okay. That will not cause a problem.
Silicone oil, for other reasons like chronic TRDs, and maybe you expect a gel-like subretinal, or to prevent bleeding, or any other situations?
So there are some situations, like suppose a patient has to fly. I've had patients where they have to fly. That's number one. Second is patients who are monocular. So the other eye is blind.
No.
And
These two situations, I think all of us use silicone oil.
Right.
I was other situations, like if you find a chronic TRD or to prevent bleeding, expect nephropathy patients or something.
Tamponade, I think there's a lot of individual preferences for oil, gas, and all that stuff. But as Kamal said, even in our practice, we are not very aggressive with oil. We do manage many patients with gas for many reasons. Number one is you don't need another surgery. And number two is when you have removed all traction, and when you have done a near complete job, and regarding these breaks which you are telling, we have to very carefully examine the peripheral retina to see whether we have created any small iatrogenic break. And what we do is we plaster the inferior retina with laser. I mean, just plaster, because we removed the vitreous, so there's no question of any reproliferation or anything like that. So inferior periphery is plastered with laser. And you can use oil in complicated cases. In complicated cases, patients who are on dialysis, sometimes we put them on oil because they have got a very high chance of recurrent bleed, and oil acts as a tamponade to prevent bleeding. So there are some specific situations, but otherwise, as Kamal sir said, is that more often gas and if necessary, oil.
Actually, coming to your question, sometimes it's chronic TRD, and honestly, I've done it many times. Don't even put air in there. If you have not caused any break, just leave it. Because a lot of times, if you're trying to put air in there, trying to flatten that retina, it will never flatten because it has been detached for a long time, sometimes months, sometimes years. You are just fighting a battle that you cannot win. It's okay. So there is always tomorrow. Just leave it. Not even air. It's okay. Just leave it.
The basic tenet being no tear, no air.
Right.
No tear, no air.
But in one situation where Dr. Giridhar said, like you have a you expect bleeding in those eyes, probably sometimes we tend to put.
And silicone oil, and the usage of silicone oil, somebody put it very nicely, that it's a complement to a well-done surgery, if required, whenever you use it. It's a complement to a well-done surgery, rather than being a supplement to a poorly done surgery.
Correct.
Sometimes in one-eye patients whom you want to ambulate very fast, I mean, we inject oil sometimes.
You're right.
Thank you.
Yes, ma'am.
I'm Dr. Maria from Lagos. My question is, you mentioned that after the retinal detachment surgery, some of their patients are still phakic. My question is, how long do they remain transparent? How long do their lenses remain transparent post-surgery, and what are the special maneuvers that you carry out to prevent them from developing cataract?
So that's a very good question. But many of these diabetic patients are young patients, and they will remain phakic forever. I've had patients who have remained phakic for as long as I've been in my practice, and they had just air or gas. So the cataract formation in a younger patient is slower or later compared to older patients. And older patients, if you do vitrectomy within a year, most of them will need cataract surgery. And the maneuver, of course, you try to avoid any iatrogenic damage to the lens. Of course, with oil, of course. So that's another reason to avoid oil if you can. As you can probably see, I'm not a big fan of oil. In fact, in detachments, I also rarely use oil.
Thanks, Kamal.
Thanks
a lot.
Thank you.
Very nice presentation. We move on to the next talk by Dr. Muralidhar, and he will be talking on simple vitreous hemorrhage may not always be simple.
Thank you, Giridhar. We all know that vitreous hemorrhage is a common indication for vitrectomy, and whenever we see the list and we see a patient with PDR vitreous hemorrhage, we are happy because generally the surgery is considered simple, safe, and this is the kind of case where we say, we ask the fellow to start, okay, you start off this case, let us do some core vitrectomy, let me see how you do core vitrectomy. And because vitreous hemorrhage, if the macula is normal, patient has good outcome, and compared to a macular TRD, combined TRD, etc. But occasionally there are some surprises and challenges. I'll just go through 3 or 4 slides with some texts, and then we'll show some videos. Now, what are the surprises and challenges that can come our way, when we are expecting a simple surgery? One is that there could be an underlying retinal detachment or a traction detachment involving the posterior pole when you thought it was only a vitreous hemorrhage, quick in and out. Second is unrecognized area of retinal elevation when there is a dense hemorrhage. And when you are doing surgery, you don't recognize this, and you end up, eating up retina and create a large retinal break. And surprisingly, this can happen. And sometimes the clots can be firmly adherent to retina. This is more often likely to happen in an intraoperative bleed rather than a long-standing vitreous hemorrhage. And occasionally, you can have a peripheral area of traction and hemorrhage. And unlike the membranes in the posterior pole and near the orchids, the peripheral areas of traction are very difficult to dissect in a diabetic eye. And sometimes we may end up with large retinal breaks in this region, or if you're not able to really dissect these membranes, you might have to supplement them with a buckle if there is an unrelieved traction. And all of us struggle to remove the blood-stained clot behind the lens, which is a clear lens. And a clot stuck to the hyaloid face behind the lens is always a challenge. And lastly, there could be a troublesome intraop hemorrhage. Now, how we can minimize and anticipate these surprises? One is thorough pre-op records. If you know beforehand, before the patient got vitreous hemorrhage, if you have seen the patient, if you see the records, you know very well how much proliferation was there, which areas had proliferation, and whether it could be simple or it could be difficult. And a B scan, in all cases of hemorrhage, B scan is mandatory to study the vitreoretinal pathoanatomy. The most important thing to know is how much is the PVD, which areas have the vitreous detachment, so that you can safely identify and say, okay, I'm going to go in the nasal area or temporal area, wherever there is a gap, wherever there is a good PVD, you would go in and start eating the posterior hyaloid face. So that's the most important thing. We always do a B scan one day before the surgery in order to see which area we need to go in when we do surgery. Now, this point, Giridhar has already highlighted that in a patient with a dense intragel hemorrhage, I make sure that I do a very good skirt excision, because as Giridhar said, this is one of the important factors for causing a hazy view in the immediate post-op period. In fact, in a patient with dense vitreous hemorrhage, you can see that the blood just leaches out of this blood-stained gel. And even that can happen even during surgery. So I make sure that I really excise this blood-stained gel as much as possible. So this is an important step. Even when there is no traction detachment, even when there is no detachment, no proliferation posteriorly, in every case of an intragel, he makes sure that you have removed the gel, that blood-stained vitreous gel. This is a patient who had dense hemorrhage. There is a PVD. We have identified attachment to the disc and a temporal retina preoperatively. We can start with the vitrectomy. You see that the vitreous hemorrhage is so dense. Now we have identified that in the upper nasal area there is a cleavage, or there is a gap, and then we are able to make an opening in the hyaloid face there. We are making an opening in the hyaloid face. And once you are able to safely make an opening in the hyaloid face, that's your starting point. We just keep on enlarging that area, progressively all round. See, now you have made an opening there, we are enlarging that, progressively all round. Ultimately, this is the last area. This is attachment to the disc and the temporal periphery. This is the last area of anterior anteroposterior traction that Kamal was actually emphasizing. And you see a large area of clot adherent to the posterior pole. Actually, it's adherent only over two areas, at the disc and temporal to the macula. And you can just see that that's the two areas of traction, the clot that's adherent, one in the temporal side, one on the disc. Now, important thing I want to highlight here is that after we did all that, you can see there is a small stump at the disc. But I'm not happy with the way retina is looking. There is a blood-stained kind of a appearance of the retina. In fact, this patient had vitreosis and had actually a thin layer of hyaloid phase attached to the entire retina. So actually we are trying to identify and remove that hyaloid phase which is blood-stained. You can see that there has been a vitreosis, there is a blood-stained hyaloid phase which is still attached to the retina. That's what I am removing from the posterior pole now and trying to detach it from the posterior pole. And if you had not done this, this might cause ERM in the post-operative period. So it's important to recognize the phenomenon of vitreosis, which is quite common in diabetic eyes. So after you have thought that you removed all the hyaloid phase, there could be a thin layer of hyaloid lurking behind. And how much of this we have to remove? In this eye, I had a dilemma because that seemed to be plastered right from the disc up to the periphery. And when I was trying to detach it beyond the arcades, the membrane, the hyaloid phase becomes very flimsy. And often it is difficult to remove it because it is very thin, it just fractures easily. And I actually did not do a very aggressive separation of this hyaloid phase, beyond the arcades for fear of causing, more breaks and more damage. I think as long as you have removed quite around the arcades and the posterior pole, that should be more than sufficient. So it's important to remember that vitreosis is there, and you need to remove that hyaloid phase, which often may be difficult to identify. You could use a tricard stain if you want to do that. Sometimes we clear the intragel hemorrhage. There is a large amount of subhyaloid hemorrhage, and you can easily remove it with your cutter. But there is one area here which is not getting, kind of aspirated easily. So it's not coming. Generally I don't use a soft tip cutter. I use the vitrectomy probe itself to remove the loose hyaloid blood. But what's happening here is not coming easily. That is because there is a hyaloid phase covering that hemorrhage. So unless you identify that and engage that and remove, sometimes you may not be able to remove that. And it's important to identify that and make sure that you address that and you remove that hyaloid phase. With the soft tip cannula also, you can see that it's not coming so easily, and there is the hyaloid phase which is preventing aspiration of this subhyaloid blood. And it's important to remember this and remove that in order to be able to remove that large last piece of subhyaloid hemorrhage. That's the hyaloid phase now which is being removed, so that now we can clean up the entire subhyaloid hemorrhage completely. Now it comes easily. Even with the cutter, it comes off easily. Sometimes there could be underlying proliferations, which sometimes on B scan you just see them as focal tractions, and unless you are careful, you might end up causing a retinal tear here during the bridging area here if you think that the retina is not elevated. In fact, it is elevated like a fold here. And how we can identify this, you have to be very careful, clear the subhyaloid blood, and only when you are sure that the retina there is a cleavage between the retina and the hyaloid phase, then you can you need to really clean it up. So it's not unusual to find actually what was a vitreous hemorrhage and a subhyaloid hemorrhage turned out to be an area, a surgery of traction detachment. You can see that's the disc and that's the macular region with extensive proliferation. So this is some of the surprises that you can find during surgery in vitreous hemorrhage. So this ended up being a TRD surgery. The last video, actually this is a patient who had clots stuck to retina. This happened intraoperatively. Sometimes these clots are so much stuck to retina, and as Kumar was mentioning, removal of these clots becomes another surgery by itself. And here actually I am trying a bimanual resection to remove this clot which is stuck very close to the macula. That's why I want to remove this, and so I'm using scissors, a bimanual surgery I had to resort to remove the clot. And since in that particular set we did not have a 25 gauge scissors and we had a 23 gauge scissors, I put in a 23 gauge cannula so that I was able to use a 23 gauge scissors to really remove the clots, as you can see. So sometimes you may have to switch over to bimanual surgery when the going gets tough. So I think I'll stop at that and conclude that vitreous hemorrhage is a common indication for vitrectomy. A careful pre-op evaluation will go a long way in identifying some of these tough cases. We can plan the surgery well and avoid iatrogenic damage. Thank you very much.
Alarm bells have started, so we have to wind up now. So we move on. I think we have had a very good discussion. Some of the points that I had to say, I think already has been told. So, sorry. So we'll go this way. Yeah, so my talk is when to use chandelier and when is bimanual surgery indicated in proliferative diabetic retinopathy. Actually, I use chandelier in advanced cases of PDR. And when I started using the chandelier a couple of years ago, I realized that it gives a very good diffuse illumination, and therefore actually in many cases of proliferative diabetic retinopathy, I feel it improves the quality of surgery. So I use the chandelier quite often in vitreous surgery for PDR because I feel it definitely improves outcomes. You can see things much better, the periphery is seen much better, the aura and the base excision is much better. So there are various chandelier systems that are available, and also published in literature. There's a single fiber system, there's the dual fiber system where we have we can push it through 2 ports that gives you illumination on either side so that it's not just a focused illumination. But what I use is the 25 gauge single fiber chandelier given by Alcon, no financial interest, and this fits in very snugly to the cannula, and you can see just the fiber optic tip is visible there, and it gives reasonably good diffuse illumination. And nowadays there are a lot of new filters that have come that have reduced the phototoxicity significantly, that up to 3 to 4 hours you can operate without causing much of retinal phototoxicity. So where to inject where to place the chandelier is again another question. I normally place it at 6 o'clock. And it's better to go direct. Actually, this is going a little oblique. I usually go direct because the position of the chandelier and the angulation of the chandelier is very important, because you place the chandelier and then later you can't see anything much. The light is very poor because the chandelier is seeing somewhere else and it's not seeing where you want the illumination at all. So, and in complex cases where I see very dense membranes extending from aura to aura, where I know that dissection may be necessary on either side, I usually place the chandelier on either side here, as I have shown here. I don't push the chandelier on both the sides. I keep the chandelier on the inferiorly and keep this thing closed and superiorly, and so that whenever you want, you can just lift it, put it here, so that it makes surgery much easier. And sometimes I have done dual chandelier also on either side when we need more dissection and better illumination. So, and then regarding the position, if you have a deep set eye, when you keep it at 6 o'clock, sometimes when you tilt the eye, the whole thing comes off, you don't get good illumination, you need the assistant to hold it, etc. So I just bring it to the inferotemporal quadrant so that it makes things much easier. Otherwise, during surgery, it becomes a big nuisance. Lastly, it's very important regarding the angulation I showed you. Here you can see this is angulated vertically. Once you angulate it vertically, it goes right there, somewhere between equator and aura, and you can't see anything in the posterior pole, and most of your dissection is in the posterior pole, and therefore when you stabilize the chandelier, stabilize it so that you get an angulation. So chandelier is at an angle so that you get an illumination more or less going oblique, and you can see more or less the posterior pole at least 30 to 40 degrees is clearly visible. And very important is it should be placed snugly. Otherwise, half the light is coming out and your illumination is affected. So these are some of the important points when you're using the chandelier. And you can do many other things other than bimanual dissection. Earlier, I used to do a regular peripheral cryo to the sclerotomy sites, which now more or less I have stopped because we give aura to aura laser with the wide angle systems, but then it helps you to see the periphery, identify any breaks, etc. And then, as I told you earlier, for base excision, I think it's wonderful. You can see here, you can see right up to the periphery here, and you can remove all these clots which may not be visible otherwise. And you can press and then you can do it yourself. You don't need an assistant to do that, and you can see more or less 360 degrees, and you can even see the superior portion. So you can press this. That's very important. We always look at the inferior, but the superior portion also is important, because the more vitreous you leave inside the eye, I think the more chances of reproliferation, more chances of recurrent hemorrhage. The disease remains more active. You can see here, you can see, examine so well, and you can see and remove any residual vitreous that is there can be removed if necessary. So it really helps in improving your quality of the surgery. Now coming to bimanual dissection, we have 3 techniques: unimanual, bimanual, visco dissection. Now if I tell I do bimanual, my colleague will say, why do you do bimanual? I do visco dissection. So I mean, these are all individual choices, as Dr. Kamal said. But then there are certain situations where probably bimanual, you can see this is a fibrovascular tissue, and there's a lot of traction here, radial traction going all around, and this is densely attached. Now you can try unimanual techniques, the lift and cut technique which he demonstrated, where you try to go see some area where you can see, but then this is very densely adherent, and when you have an elevated retina, it makes things even difficult. You can create an iatrogenic break. Now you can see here I'm using the closed edge of the scissor and the forceps. This is another technique, and you can see here this is the second membrane here, and once you go under the second membrane, you got the plane. Once you get the plane, then the surgical dissection becomes much easier. So I mean, therefore identifying the plane, and then second thing is the instrument that you use, both are equally important. So this is a small clipping to show you a genuine indication for a bimanual dissection. Now this is another situation. We saw a lot of videos of combined detachment. Now you can see this is the hole here. Now this is a fibrovascular proliferation. Now I'm making a mistake. I'm trying to dissect this tissue from the area where there is more dense adhesion. This will not come. But you can see here, this is an area where you can see, as Dr. Gopal said, go to the periphery. You can see this small attachment here, thin attachment here. Hold it here. And once you do that, you will see that this whole thing comes en bloc, and that's because once you release that peripheral traction, that makes so much of difference. So in PDR surgery, focal areas of peripheral traction, if you release, the fibrous tissue becomes more flexible and easy to remove. So you can see here, this is the line of cleavage here, and when you're handling in a situation like this, don't pull too much, because when you pull this too much, you can create another break, or the break that is existing enlarges. So you have created this cleavage here, and then from here you extend peripherally and release the whole traction, and you can see here the whole fibrous tissue has completely come off. There is a vascular end here which has to be cauterized before you remove this. So this is just a technique to show you how you should handle a fibrovascular tissue. Don't go to the area where the attachment is more dense. Identify an area where you find that the attachment is more flexible and where you get a cleavage, and from there you start the dissection, and once you do that, then you may be finding the whole procedure much easier, and sometimes you can just remove all this en bloc, and you can see here this whole tissue has been removed, and this is the break here which has been cauterized. So this is another situation where probably bimanual is indicated. Now you can see here this is a complex PDR. You can see this area, multiple membranes are there. This is one membrane here, there is one membrane underneath it, and there is a little bit of blood here, but this area probably there is a little bit of elevation. But this is a very difficult case, and you can see here this is going end to end. This video I have shown it elsewhere also, and you can see the B-scan ultrasonography which shows the vitreosis. This is one layer, this is another layer, so there are multiple layers, and this is going to be a difficult surgery, and preoperative B-scan really tells you how helps you to plan the surgical procedure very well. So here I start from here, I make an opening from this area, because periphery to center or outside in technique, where I'm able to create an opening here, and with this opening I can reach the posterior pole. And once I reach the posterior pole, I need the bimanual dissection. Now this is a situation where nothing else will work. Your viscoelastic, your unimanual techniques, nothing is going to work. Now what I want to show you is the plane of dissection. You can see here, this is the second layer here. This tissue which is going here, that's the second layer, and you need to go underneath that. Therefore you start dissection away from that. Don't start dissection here. If you start dissection here, you will not be able to achieve anything. So go a little farther away from that, and as you're dissecting, you can see here you're created, you released that tissue there, so you got the correct plane of dissection. Now once you have done that, then you can proceed much faster, and it makes things much easier. Therefore, where you start the dissection, number one, this is below, and then you must be able to visualize the instruments. Now, when you see these sort of situations here, you don't go here first. Release, you can see there are a lot of gaps this side. Release that area first so that you know you are able to, this traction will be released. So once this is released, you can see here, go between the tissue and identify the tissue that is attached, and you're able to, you know, release the fibrovascular tissue. Therefore, I'm just showing you various techniques. Now, this is again another case with multiple membranes. This is a combined detachment, very bad case, one-eyed patient, where we have, again, I start from periphery to center. I make a hole here. You can see the retina underneath, but this again has got vitreosis. There's a second layer on the surface of the retina. And you know, you need, again, once you reach the posterior pole, you need bimanual dissection. It's very important that when we create breaks or when we see breaks, now this is an iatrogenic break I created when I did some cauterization on the surface of the retina because I had no other choice, because in elevated retina I couldn't apply any pressure. So finally I ended up, and I need to remove this fibrovascular tissue, otherwise this traction will not be removed, and once this traction is not removed, post-operatively you will find that the hole becomes much larger. Here again I show you the dissection techniques. Again you can see from periphery to center, it's been dissected, and you can see here this tissue is elevated. So I would like to conclude my talk with a wonderful article that has been published just really recently, just about a few days ago, online in the Retina Journal, about a large experience by my good friend in Delhi, Dr. Shroff, where they have shown the results of about 300 plus cases of bimanual surgery using microincisional vitreous surgery. The incidence of iatrogenic breaks in their series were about 40%, but then it all depends on how complex cases you take. The more complex cases you take, the more the iatrogenic problems that we get. Therefore, in conclusion, individual choices for surgery, but there are specific situations today that we may need bimanual surgical techniques. So we can have some questions, and I think we will have to wind up because it's already 1:30. Any questions or comments? So thank you all for your kind attention, and I hope you found the course interesting. Thank you.